Morning, everybody, or good evening, depending on where you're located. Like as stated, my name is Marissa Gayle. I've been a radiation therapist at Montefiore Medical Center for over the last 14 years, and I've been both a simulation therapist and a therapist that's worked on a variety of different machines. So we have an interesting talk. Hopefully, we'll get some great information that this could be useful in your clinic. I'm going to put up a Zoom poll. And basically, I would like to get some information to find out what method of stimulation does your clinic use. It's an anonymous poll, so go ahead and vote. We'll give you guys about a minute, and then we're going to see what the results are. Okay, so this is good. Most of the clinics are using a CT simulation only. Okay, so the talk is going to mostly focus on a CT simulation, but we'll give some background information for a conventional sim so that for those that are still using one, we'll have the same information. Okay, so what happens at the simulation? A couple of things. We can either gather information for treatment planning, and it will either be forward or inverse planning, depending on which modality that you're using. If you're using a conventional sim, then yeah, it'll be forward planning. But if you're using a CT sim, it'll be inverse planning, and we will talk more about that later in the lecture. But we're going to make sure that the patient positioning is key. So we want to make sure that it's in a position that's reproducible and that where we put the skin marks is in a stable area. And of course, we want to educate our patient. And then these are the two simulators. Earlier in my career, I have worked on a conventional simulator and it was very helpful, but most clinics today will now use a CT simulator. The conventional simulator, usually you have a predetermined treatment angles, and we say it's forward planning. So with a conventional simulator, you'll have to lay the patient, of course, on the couch. You would have to do, make sure you have an immobilization device. But before you start planning, you would have to gather certain pieces of information, such as the SSD, the separation. You would want to take the contour of the patient, the field size, images. You need all this information first, and then you can start making a plan. With a CT simulator, the treatment planning is done after the simulation is done. So it's called inverse planning. And the treatment planning is done based on the CT scan. If you're doing any type of IMRT technique, you would need to use a CT simulator. Some of the things that happens at simulation: determine the patient position. I have slides later in the lecture that will discuss that in detail. Determine the Isocenter. We're going to pick what area needs to be treated. So the Isocenter can be picked by either myself, a therapist in some instances, where it's very obvious. A lot of times on palliative cases, we may just pick the Isocenter. On certain cases that are more detailed, maybe like an SBRT or an SRS, the doctor will come in and he will tell us exactly where he would like that Isocenter to be. At the time of the simulation, we're going to do, of course, a CAT scan to scan the area that we need to treat. And then we need to document. The first thing that we need to know in their documentations is that we need a consent, that the patient is allowing us to do this. We also need documentation from the MD as to what he requires, like, what area are we treating? What kind of device would he like to use? What type of plan is he thinking of? Is it going to be a 2D plan, 3D plan, IMRT, VMAT, SBRT? SRS, whatever it is, so we know exactly what immobilization device that we need to use. And then we need setup pictures so that we can then tell the other therapists exactly what we did. Pictures of what we use, where the Isocenter is, and what positioning the patient is. Documentation is key. And then we need to educate the patient. So different clinics might do it differently. So at my clinic, for example, we may have a nurse talk to them about some of the side effects. We may have a nutritionist speak to them about what they would need to eat to maintain their weight. And then we, as the therapist, may also reiterate that same information, but always encourage them to come in for each and every one of their appointments to try and not miss any appointments. And of course, we'll go over like side effects. So once we're going to start, I have pictures to explain some of these terms that I have here. So the CT reference points, BBs. Those are radio opaque markers that we'll put on the patient so that we can see exactly where we tattoo. We may use wire to either wire a scar, wire out breast tissue. We may want to, if the patient's having pain, the doctor may ask us to ask the patient to point to where the pain is, and we may wire that area. A lot of times for different CT scans, we'll use we can do oral contrast, which would be gastrographin, and we'll use it to make sure we can highlight the stomach and the intestines. We may use IV contrast to highlight, especially for head and neck, like lymph nodes. We will use bolus in certain areas. For some head and neck patients, we will use bolus to put on their neck. We'll use bolus for breast, bolus for anal verge. It's a variety of different things that we use, and is dependent on what the doctor would like to do. Also, before a scan, there may be some type of preparation. We may have the patient have either a full bladder if we're treating their prostate. We may have them have an empty bladder if we're treating, let's say, their bladder itself. We may have the patient, especially our prostate patients, do a bowel prep, in which they will do the night before, drink some magnesium citrate. Then the morning of the scan, they may do like another fleet enema to make sure there's nothing in the bowels. And then we ask them to have like a light breakfast. And that's just so we know that their bowel is empty. There are certain times that we may ask the patient not to eat because we want their stomach to be empty, and they may have a morning appointment. We always scout the images because once we have the patient on the couch, you want to make sure that the patient is straight. Making sure that the patient's straight is going to make it easier for everybody. So each and every time that you set the patient up, that their body's in a straight alignment. So we may do a quick scout to see what it looks like. And if the patient looks a little bit rotated, we will fix them at that time before we continue on. And then each site may have a set preset protocols per anatomical site. So for example, if we're treating a prostate patient, we will scan from L4 to the mid-femur, or just to cover external genitalia. So that's like an area that we would scan. If we're doing, let's say, a GYN, we will start scanning from T7 and going all the way through to the mid-femur to encompass external genitalia. If we're doing anything in the head and neck region, we will do, of course, from the top of the head, and we may scan to about the carina. If you're doing anything in the thorax or chest, we would definitely want to get, let's say, the apex of the lung all the way through the diaphragm. If we're treating the brain, of course, we'd want the entire brain. And the spine would depend. We want to give them enough area so that they can count. So if it's, let's say, C-spine, of course, we're going to give them the base of skull and maybe some vertebral bodies into T-spine. If we're in T-spine, we may scan lower into L-spine. We want to give them enough information so that they can count and know exactly to ensure that they're on the correct vertebral body. Also, depending on the type of technique, if it's IMRT, depending if it's like an SBRT or SRS, we may change this, the thickness of the CT slices. So for example, at my site, we may use 2.5 millimeters for the majority of our scans. But if we're going to do, let's say, an SBRT or an SRS, we will change the thickness to 1.25 millimeters. And this is just some pictures of the BBs, a picture of the wire. And then in the next picture, we use reusable markers for each and every patient that are disposable. So each patient gets their own marker. And before we start, we like to wipe down the patient's skin with an antiseptical wipe to ensure that once we start marking them and then do tattooing, that we won't introduce any type of like infection to the patient's skin. So we use, at our site, everything's disposable. It's one-time use. The patient uses it once, and once that patient is done, we throw it out. I have more pictures of bolus like we talked about. So the top one is just this thermoplastic bolus, which you can obviously heat up and then you can mold it to what you need it to do. We have superflab. We will use wet gauze on occasion. At our facility, we do have a 3D printer, and we will use it to make bolus. This bolus that I have is was for a patient who had like a basal cell carcinoma, and it was on his eye. So this is an outline of the patient's face. Skin marks. What is the purpose of skin marks? It's for a CT reference point. It's so that we know where our starting point. Then we have positioning, triangulation or biangulation. So we know triangulation is using 3 points. And we're going to set up the patient to 3 points on the skin surface. We tend to use triangulation for the majority of our setups. Biangulation is just using 2 points. Generally, we would use biangulation if you're treating a breast patient. I would use biangulation if I was doing extremity, like an arm or a leg. And then we talked about skin marks need to be placed in a stable location, meaning that it should not be on loose skin. Some patients, they may have, let's say, a big belly. So you may want to make sure it's a stable spot. So you may, at times we have moved where we want the isocenter to be so that we knew it was stable. We may move it like maybe 5, cm sup or 5 cm in, just so that it was on a stable location. And we would mark that as our isocenter. And then we'd also give like a sup and an inferior mark to make sure that the patient was straight and level. You want to make sure that's midline so that you can basically eyeball the patient. You know that, yes, this patient is straight. Like I said, avoid loose skin or movable parts. The axilla is another loose spot. I don't really like putting tattoos, let's say, on breast tissue on female breast because that tissue is very movable. Additional marks is needed. So in extremities, I may give a few more marks to ensure that they're in the proper place, that you know that the arm is exactly, that you're able to reproduce the same position. Because at times the arm can be a little bit more akimbo or less akimbo, but if you have more marks, it will lead to a better setup, and it'll definitely be way more reproducible. Again, this is a slide that talks about the triangulation, a 3-point setup. And we can see from the slide where the 3 points are. You would have a mark on the laterals, right and left lateral, and then you would have a mark midline. And then it would ensure that the patient is definitely level and is straight. I also like to give, like I said, a superior mark and an inferior mark just to ensure that the patient is straight. Biangulation, as stated before, is a 2-point setup. I generally use biangulation marks for breast setups and, like I said, for like a femur, a lower leg, any type of arm. Generally, when you're doing a biangulation, you need to give a tabletop or a setup SSD so you know that's your starting mark, that your lateral SSD, your lateral tattoo is going to line up to. And then you would have like an interior tattoo, and then you'd make sure that those 2 points are in alignment. As mentioned previous, documentation is key. You need to document everything for numerous reasons. The first one is so that when the patient is done with the simulation and they go onto the treatment machine, the other therapists know exactly what you did. So we need to document what immobilization device that we use. Did we use a wing board for a lung patient? Was it a head and neck board? Was it like a vac lock? What is it that we use to mobilize this patient? Then it's skin marks. Where did we put the tattoos? How many tattoos did we put? Especially if this patient's been treated before, you want to document where you're treated, show pictures so that there's no mistakes. The therapist on the treatment machine know exactly what marks to go to. You want to give sufficient information like tabletop, SSD, so that it will help in the setup. Does the patient have bolus? What type of bolus? As in the images I showed before, is it a thermoplastic bolus? Is it going to be a wet bolus that we will create each and every day? And they will say like how many pieces of gauze we need to use. Is it something custom like the 3D bolus that we'll be using each and every day for this patient's treatment? And not only what the bolus is, where is the bolus to be placed? And we take pictures of all of this that's then uploaded to our hospital chart. And then for the CT sim, what kind of preparation did the patient have to do for the sim? Do they have to do a bowel prep? Do they need to have a full or empty bladder? So also these notes need to be added into documentation. So for example, if we have a prostate patient, we know that each and every day they need to have a full bladder, that they need to drink, 16 ounces of water, and that the patient is told what they need to do each and every day for their treatment to be successful. Also, we need to tell the patient what time they're coming back, when they start. We also need to notate if we gave the patient contrast, how many scans we did so that the planners and the dosimeters and the physicists know which scan to use, because we might have done a couple of scouts to make sure. And then if there's anything unique, you need to document so that they will be able to, so that you'll be able to reproduce the setup. And then patients have questions. They may ask, like, what happens at my treatment appointment? And this is a time to explain to them, you're going to come back in a week. When you come in, it's necessary for you to have a full bladder. You're going to have to change. And depending on the area that you're treating, you will tell them what needs to be changed, how to put on a gown. You let them know that they're not going to feel anything, that, I like to tell the patient they just need to relax as much as they can and breathe normally. And it's kind of overwhelming for some of the patients because they do not know what to expect. And I feel it's our job to kind of try and put them at ease and just to maybe explain everything step by step so they know what to expect. It says, do I need to prepare? So some patients, yes, they do need to prepare. So like I said, if it's a patient that we're treating something close to their stomach, they may not want to, they may be told that they shouldn't eat breakfast. Some patients may have some kind of anxiety in their head and neck, and they may need to take an anti-anxiety medicine before we bring them into the room and we treat. We've discussed having a full bladder. Each site may have something different depending on the patient's disease. A common question is treatment painful? I tell patients I've never undergone radiation therapy myself, but to my knowledge, it's like a giant x-ray. They shouldn't feel anything, but I never discount what the patient said. I've had at times patients says they felt something was tingling, they tasted something. I don't discount what they're experiencing, but generally I like to tell patients they should not feel any type of pain. And then we will discuss again what the side effects of radiation are, which generally they may get some reddening of the skin, hair loss. Sometimes the skin will break down or they'll get either, moist desquamation. Head and neck patients may have trouble swallowing. They may lose their sense of taste, smell, depending on what we're treating. We will definitely let them know. And we will say that we will continue to monitor their side effects. And if they have any questions, they have the ability to reach out and talk to their physician. What's a good setup? To me, a good setup is a setup that can be reproduced by any of the therapists that work that machine. So to get to a great setup, I always say that it has to begin at the beginning in the CT sim. So for one thing, I like to make sure that the patients change and they take whatever area we're treating, they take all their clothes off, meaning that they should remove their bra, an undershirt, chains. All they should have on is either a hospital robe, and then we will lower that. And we also will cover them to maintain their privacy, but we want to have access to the area. So we want to have clear access to the treatment site. And then we want to make sure that the patient is as comfortable as can be. We all know that the treatment table is hard and uncomfortable, but we want to make sure that if the patients are able to raise both hands, that they can do that. And that wherever we're putting our Isocenter is in a stable place without loose skin. So we're going to look at the picture that's here in the slide, and we can see that the patient here has his arms up. He's holding a wing board, and he has probably like a headrest underneath his head. He doesn't look like from the picture that he's struggling. He looks pretty comfortable. That is a position that's definitely very reproducible. Also, when we're creating these positions, we want to make sure for clearance on the machine, especially when we're rotating the gantry, that if we're doing any type of extremity, that especially let's say the arm is not sticking out so much that we may have any type of collision. And I always say on the treatment machine, if you are in doubt of anything, you can always do a dry run to ensure that there will be no touching or clipping of the patient with the gantry. So as stated before, I said the patient comfort is necessary. The table is hard, so we're going to try it's better to have the patient that is straight than crooked. You don't want to have the patient's hips to the left, their shoulders to the right, and their head in a different direction. You want to try and make sure everything's in an even plane. And you want to straighten the entire patient, not just like what you're treating, because you never know what may happen later on. And also it will make it easier when you set up. You want to make sure that sometimes patients who have bigger butt, that they're lying flat on it. They're not like off to the right or off to the side. That if their arms are up, that it's all the way up and that they're comfortable. Like I stated before, you don't want to have extra clothing, blankets, cushions, jewelry, because that will end up in the way, or it may be in the beam path. So you just want to make sure that they're able to remove those items. Sometimes I've had this happen on occasion with cases that are palliative. You may not be able to get a patient straight because they can't stay still in that position. The key thing is that when you set these patients up, they have to be able to stay still for about, I like to tell them 20 minutes. So a lot of times with some of our palliative patients, they can only, let's say, lean to the right, but they will be still for you leaning to the right. And that way that may be their position that's good for them. And that may be the only way that you can then reproduce that. We talked about custom devices. And each place has different type of custom devices. Some places will use reusable vac locks. Some places are still using alpha cradle, which you're mixing two chemicals together and you're placing it in a bag. It's not so much in line with being green because it's one-time use and you have to then throw that out. We use a lot of like thermoplastic masks for the patients, wing boards, leg molds, knee cushions. All these things could be added to a device or could be used for the patient. Again, we're going to talk about watch for skin folds. So when you're setting up a patient, you do not want the skin to touch. It may create a bolus effect, especially in breast patients where you would want to make sure that you have sufficient space when they're turning their head away from the contralateral breast. I have more pictures and examples of each setup of what they should look like, and I will show them later in the presentation. So we're going to start with the first setup, which is head and neck. Here we have a picture of a head and neck. There's different varieties of head and neck boards. Some have poles that the patient would hold, and that will be like to pull the shoulders down. Some have shoulder claws, and they're different type of masks. Some have a 3-point mask that will just cover the head, and some have a 5-point mask that you will get coverage of the shoulders and like the upper supraclav region. Depending on what you're treating, you will use a different mask. My clinic tends to use the 3-point mask for just brain. We may use the 3-point mask also for patients that have a trach because it will allow access to the trach. Whereas if you put the 5-point mask, you may be covering up the trach. And you may not want, like if the patient's trach has a lot of sputum coming out, you wouldn't want that all over the mask. I tend to like the 5-point mask. To me, it's excellent. The patients are unable to move, and then you're ensuring that the head and the neck and the spine, everything is in an alignment. You will mark the mask as to where you want the isocenter to be or where the doctor has decided to place the isocenter, and you can still use those disposable markers to mark it for the patient. On our head and necks, I will mark where the isocenter is, and then I will also give a patient an inferior mark on maybe around the sternum to ensure that they're in a line, and I'll mark the top of the mask so we know that they're on left to right. Also, with the head and neck setups, we will use the different headrests. They come in a variety of sizes and shapes, depend what works best for the patient. My site also likes to add the mold care cushion on it because some head and neck patients just can't get their head all the way down. And it's another way to ensure the head placement. So I took some pictures of at my clinic. So we can see here's how it was documented. So we have a sheet that we're able to add the photos to. We would put, of course, on this the face photo with the patient's face, name, date of birth, the date that they were SIMmed. And then we'll have here what we're treating and what the setup is. So we see on this is the patient's on a supine head and neck board. We'll talk about the aquaplast mask that is here. We say what headrest the patient was on. He has a mold care cushion. The patient is actually holding a ring so his arms are not dropping. We have a knee wedge underneath his knees, and then we say where the triangulation is at Isocenter. The next setup is a thorax. So like we said earlier, when we're scanning the thorax, we will want to get anything the top of the apex all the way through to the diaphragm. And different sites sets up their lung patients differently. There's whatever works, whatever your doctor likes, and it works for you, that's what your site does. So there's nothing's right, nothing's wrong. A lot of times a lot of sites will use a wing board, which has that the patient will lay on. Some sites will then also add a vac lock to that to ensure the correct same arm position. Generally, when we're treating the thorax, we like to have the arms up. There's a picture here where the arms are down. If a patient's unable to keep their arms up, there's been times we have simmed them with their arms down, but we knew at the time that, let's say, they were going to be APPA, so that the arms would not be in any way of any of the beats. Again, we have another abdomen. And also, if we were treating the abdomen, I wouldn't have his arms on his chest, but we can see here that he's in a mold. You can see the vac lock underneath the patient. You can see that the patient's on has something underneath their head. And all these positions are very reproducible, and they also would have marks for their isocenter that you would then have to triangulate. And also in an abdomen setup, I would give them the triangulation, and then I will give them, let's say, a superior alignment and an inferior alignment to ensure that the patient is straight. And these are just some more setups that different sites use. And here's again another example of a vac lock, another example again. And then this is for the pelvis. So some sites will use, like I say, a vac lock for the pelvis. Other sites have pieces that they can index into the treatment table to ensure that the patient's legs are in the same position. And when you're treating the pelvis, you'll have the patient hands on their chest if it's like a prostate, but if it's a GYN, we tend to put the hands above their head in case we need to treat the periaortics. So here is another setup for my clinic in which we're treating a prostate SBRT. We still use this, whether it's a prostate SBRT or a regular fractionated prostate, it's the same setup. The patient's going to have a vac lock. Well, our clinic uses alpha cradle, so that's what's under his leg. He has a pillow underneath his head. His hands are on his chest. And yet again, we can see here, he has, the ISO is marked. It's about L4. And you can see, I don't know how good this picture is, but you can see where we put the BB and that we have where you can triangulate. And then there's an upper mark where we'll use for superior alignment. This is a setup of our GYN patient at our clinic, and yet again, the same thing. You can see the sup and inf alignment. We tried to keep the area that we didn't need to expose was covered. And here again, the patient has her arms up. She's grabbing a wing board. Her arms are up. She does have a vac lock for her lower legs. And then we tattooed, so she has the 3 points, and then she does have a superior alignment on her belly and an inferior alignment to ensure she's straight. And many of our doctors like to put the ISO about L3, L2 on our GYN patients. And we see here, there's some extra notes. If you notice here that this patient has to have a full bladder, and we put in the setup note, she needs to drink 2 cups of water, because that's what we gave her at the time of SIM, and that's what the plan was based on. Then the next setup we have here is for a supine breast. Our clinic does a breast board. So we have the patient on an angle board, and the angle board is at 10 degrees. We then gave them a headrest, and we just marked where we put the headrest. Also, we will make for each patient to ensure that their arm is in the same position. We will make for them a alpha cradle or some or some sites will also use a vac lock to ensure that the arm is in the same position. And then there's a pole that the patient is grabbing onto. So this is an example of biangulation, where, as you see in the setup instructions, we have a tabletop of 21.5. And then we will use those for the lateral tattoos to make sure that they're on. And then you can see here the patient had medial tattoos. She is a 2-field breast, this one. She's not, no, I'm sorry, she's a 3-field breast. I see the superclap tattoo. So we're gonna line her up. And you can see by this, she has a knee wedge underneath. She's nice and flat. She's on the angle board and her arms up. Our site also does prone breast. So same thing again. We talked about what device the patient is on, and she's on our prone breast board. We tell exactly where her hands are located. For each one of our prone breasts, we'll make them a custom cushion so that their arms and elbows are in the exact same position, and it takes a mold of which way their head is turned. For our prone breast setups, we'll make sure that the back has 3 tattoos. And then we'll make sure that this again is a biangulation. The patient has a tattoo on the medial and on the lateral aspect of the breast. That will be the ISO, and then we will do 100 SSD setup. 100 SSD setup. Then we have extremities. So one of the pictures I wouldn't really do. That's the lady to the far right with her hand up. I would have had her hand down and akimbo. I wouldn't have it up because I wouldn't want to be too close to her head. But for extremities, you're going to have to be a little bit more clever because you don't want the arm too far out because you don't want to have any type of collision with the gantry. You want to make sure you're able to clear your bore, but you also want to be able to set up. So I feel like extremities are a little bit more tricky, but I like to use an immobilization device, either making like a mold care cushion or any type of like using an aquaplast to immobilize the extremity. Sometimes when you're treating extremities in the picture that's on the left, the leg that you want to treat, you tend to raise that one up and out the way, and the one that you're not treating, you kind of have away from you. That's what's pictured in this image right here. And yet again, the patient is on a vac lock. And then again, they use the thermoplastic molds to encompass the patient's foot. I've also treated patients' feet, just putting it in a box of rice to make the whole dose even. Key points to remember with setting up patients: you must document everything so that the next person knows exactly what you did. Making sure you have good documentation to reproduce your positioning. So like I showed you in those pictures, our site takes pictures and we upload it, and it can be found in every patient's as part of their set. And you want to document everything, exactly what you did. How much water did they drink when they had a full bladder? Or was their bladder empty? Was the patient nervous when you made a mass? And they may be a good candidate for getting, something to take the edge off, be it Ativan or whatever the doctor would recommend. So you want to document all these things. Making sure that the patient is straight is key. I can't tell you how important that is because it is extremely difficult to recreate someone that is crooked. And it will basically take a lot longer to make the patient crooked than it is to make sure that that patient is. And then you want to have appropriate skin marks. You want to make sure that when you do tattoo, that the tattoos were able to stick, that you're able to see them, and that the marks are there so they're there so that the patient can be treated correctly each and every fraction. And we discussed again, like the mark shouldn't be in any place where the skin is moving. You want it in a stable spot. Thank you. Is there any questions?
Thank you very much, Marissa. This was really helpful. Looks like we have 2 questions in the chat and then one in the Q&A. So the first one question was, what does BB stand for?
You know what? I don't know. I'm going to find out for you. I've always just called it a BB. Like it's just like a mark that was given. That's a good question. I never thought to know what it stood for. I'm sorry. I will find out for you though.
Someone in the chat called it a ball bearing.
That makes sense. It's a mark. It's a little circular mark that you're placing at the where you're marking your ISO, so that when you do the CAT scan, when physics and the dosimetry and the planning team can see exactly where the Isocenter is. So ball bearing doesn't sound too far, but I can definitely find out that information when I go into the clinic on Monday.
Okay, great, thank you. And the other question from the chat is, could you briefly repeat what you mentioned about the 2-point setup?
On a 2-point setup, you want to make sure you have a starting point. So I say you need to have the tabletop or a setup SSD. Let me see if I could go back to this page. So you'll see here in the picture to the far right, they're giving you a distance. That will be like the tabletop. So that tabletop is going to match where your lateral tattoo is. So if you bring the table up, and let's say the tabletop is 16. So then you're going to look at the patient where you're tattooed and you notice that the lateral tattoo is not at that mark, then you would roll the patient to the laser at the tabletop at 16. So your lateral tattoo matches that distance. And then you also make sure it's in a line with the tattoo that's anterior. We generally use biangulation for breast setups the most. And like I said, some like arm setups and leg. Majority of the time, we will use a 3-point setup, but every now and then biangulation works well.
Thank you. Another question is, for pelvic cases, do you include a portion of the abdomen in your images?
Yes, sometimes we do include a portion. It just depends on, everybody's anatomy. Sometimes the doctor will ask us to scan more than is necessary, especially if they know there's maybe some other things going on. Also, if you're scanning higher, a lot of times the doctor will ask for the patient to drink the gastrographin. That will be the contrast that they can drink, and it will highlight the intestines.
Thank
So
you.
generally for like GYN cases, yes, you will definitely have some bowel will be in the CAT scan, maybe in the field.
Great. About your bowel protocol, do you use an enema on scan date, or do you let the patient get drugs and prep their bowel to do at home? And if so, how do you enforce compliance during treatment?
Okay, so for our prostate patients, we like for them to do the bowel prep at home. We give them the instructions before they come in for their scan. They're told this in advance by the nurses, and they're told what to do. And they're given the times that they need to take the magnesium citrate. They're told when they need to do the fleet. And then on the day of the CAT scan, so not all patients tell the truth. We will do a scout, and we will check to see if they did it. If they didn't do it, we take them off the table and we tell them they please need to do the bowel prep. So that's at the day of SIM. During treatment, we tell the patients, they should have a bowel movement before they come in. And for many of our prostate patients, we do a CBCT daily on them. So we will see if the rectum is full or not. And if it's full, we take you off the table. So that's about 75% of our patients will fall into that category. Every now and then, we will then in the clinic have to administer a fleet enema, and then we will give it to them, ask them to please use the bathroom, and then we will try to do the CAT scan that day. But that's a rarity than the norm. There was another part to that question.
How do you enforce compliance during treatment?
Well, we enforce compliance because we do a CBCT daily on many of our prostate patients. So looking at the CBCT, we will see if the rectum is full or not. And if it's full, then we take them off the table. Because if the rectum is too full, they may be pushing, the prostate out of the field. And that's how we also ensure that their bladder is also full. Like we're checking. We have a ovarian true beam, so we have the capability to do a CBCT daily to check these things. So that's how we're enforcing what we're asking to be done. Like in the past, before we had this technology, we went on, yeah, my bladder is full, but there was no way for me to know when I was working on a Clinac 6. And we took a film just once a week. But now that we can do imaging daily, we're able to see if the patient's bladder is full and that their rectum is empty. And if it's not, they're told to, we take them off the table and I will either give them something to drink and ask them to please use the bathroom.
Okay. Thank you. And the other is bolus. Do you apply bolus on TPS or apply during CT planning?
Depends. I work in a big department, so we have a lot of different doctors. So it goes both ways. Sometimes the bolus is planned at the time of the CT scan, and we have one there. Sometimes the bolus is generated after, and then myself as a therapist will have to either, cut the superflap to make sure it's the right size, or it may be wet gauze, depending on where we're treating. So my clinic could go either way. It could be done at the time of the sim, or it could be done after the treatment, after the plan has been created. I don't think either is wrong. It just depends on what they see on the CAT scan and what they deem to be a better and optimal treatment for the patient.
Thank you. In head and neck cases, how much contrast do you give?
I'm trying to remember the size of, it's preset. So we have preset bottles that's given and we upload it into a syringe and then it is pushed. And then we just have to generally, we push the contrast. We have to wait like maybe a minute and then we start to scan.
And could you explain to us your experience on claustrophobic patients when making a head and neck mask?
Yes. So generally when you're making head and neck masks, patients will tell you in the beginning they're claustrophobic. So what I will try to do is in the beginning, see whether we can give them something to kind of not make them feel so anxious is one. And then when we make the mask at first, because the mask is warm and moldable to the skin, they may not freak out too much. And I try to at least get the mask made and try to do it as fast as possible. Once the mask is made and dried and they're still like having a hard time, depending on what I'm treating, I will cut out certain areas to give them to make them feel okay. So a lot of times they'll say I need to be able to open my eyes. So I'll cut out little circles for their eyes and I'm gonna try and talk them through it. Try and give them deep breathing techniques. Sometimes that doesn't work. And sometimes I've had to, depending on what we're treating, I have to cut a little bit more of the mask out for them to get them through it. I do not want to compromise the integrity of the mask, so I definitely don't want to cut out, let's say, the nose. I do not want to cut out the chin, but I've definitely cut out the eyes. I've made a little hole where the lips would be so they feel like they can breathe through their mouth. But most of the time it's been just kind of talking to the patients, trying to get them into a good place, trying to let them know what is going to happen each step of the way, and if all these things don't help, definitely taking some kind of anti-anxiety medicine has been, let's say, the last thing that was offered to them that would help them get through this treatment. And some patients may need to take that for the duration of the treatment, that their claustrophobia is real, but they understand they need to get treated. So they'll probably have to come with a family member because once you give them they'll be very sleepy. And I work in the Bronx. We really don't want to send them out on the street being sleepy or having to take a public transportation home.
Thank you. How do you handle pediatric patients or adolescent patients for simulation?
That's a great question. We do have a children's hospital and we're excellent with our peds cases. We do everything that we can to get them on board. And it also depends on the age. So generally most of our children that are 5 and down, they come with a sedation team that they're then put to sleep. Because there's no way, let's say a 2-year-old is gonna really get through a CT sim, making a mask and giving them tattoos. That's just really not what's going to happen. So those cases are generally in the morning because they need to come in, they need not to be able to eat for at least 6 hours. Try to do them in the morning so they're not super cranky and super hungry. So that's for our little itty bitty ones. The kids that are a little bit older, so I would say 8, 9, 10. It's kind of touch and go. It depends on what we're treating on them and what we need to do. Some of them will get on the table and we'll make a mask and they'll be fine and they can do it with minimal, encouragement. We like to put stickers candy, we bribe the kids, to be quite honest with you. If it's something like we've done like 2-site SBRT where they're going to be on the table for a long time and really can't have them moving, they'll also be a candidate for the sedation team. Then teenagers, we kind of treat them like adults, like we encourage them to come. We try to also bribe them with, we don't bribe them with stickers, but maybe mostly with candy. Also, because we're a major medical center and my facility has a children's hospital, many of our children come with a child life department, which is like a social worker. They just deal with getting children through different medical appointments and imaging. So they will come with someone from our child life team that will just explain to them. Also, we like to have the children come in before so they get to see like the machine. They get to meet us. We let them like turn and off the lights. We let them play with the pendant just so they have a sense of familiarity and they kind of get to see the room. So they may not know what to expect, but they at least have seen us and kind of know that this is a big machine, but like nothing really is going to happen to them. We also let their parents, guardian, loved ones stay with them as long as possible.
Thank you. For thorax stimulation, the hands are by the sides. In my center, we do MV image every day or MV image every day. How do you keep both arms to avoid unnecessary irradiation?
Like I said, many of our patients that have their arms down are usually down for 2 reasons. They legitimately can't put their arms up. And we try not to do sims with the arms down. It's generally, and if we're doing it, like I said, sometimes it was something simple, like an APPA plan or a 3D plan that did not have lateral beams. And the second part was the question, how do we keep imaging to a minimum?
So they offer MV images every day. So how do you avoid irradiating the arms unnecessarily?
I don't know, you can avoid it. You can probably bring in the jaws of it, but depending on where you're treating, you may not get the area that you're treating. So let's say if their arms are at their side and you have a spine, you can bring up the blades to cut out the arms, but you won't see the spine. So you may have to go through the arms.
Mhm. Thank you. And for breast stimulation, where do you place your BB markers?
The lateral BB marker we will place, usually we outline the breast tissue with a wire, and I will put the medial BB like in line with the nipple on the sternum.
Okay.
That would be the medial. And then, I will shift over and then I like to give like, if it's a 2-field breast, I'll give an inferior and a superior tattoo so you know what the shift is. And that should be in line with the lateral tattoo.
Thank you. And how do you ensure bowels are empty during the treatment for the whole period of treatment compared to the day of stimulation?
Well, we ask the patients that, especially when the bowels need to be empty, that they have a bowel movement in the morning or before treatment. So whenever before treatment is. That's for some cases. There's other cases, like we do SBRT prostate. Well, they're asked to do a bowel prep each and every time they come in for treatment. And like I said before, to ensure that it's actually done, we do a CBCT before we treat each fraction, and then we check.
Excellent, thank you. And the last question is, does your clinic perform brachytherapy for cervical cancer?
Yes, we do.
And would you be able to give a quick summary of the role of the therapist in brachytherapy for cervical cancer?
Our role is to set up the room and do the scan. So, for example, for brachytherapy, our physician likes to make sure that the patients are pre-medicated. So the nurses will do that, and that they have a Foley. The nurses are going to do that. We will then bring the patient into our CT sim. We'll make sure that the leg molds that he needs to have, kind of like frog legs, is in place, and that the patient is straight. And then we'll do a quick scan, and that the doctor can see that everything's in place. And then he'll start inserting his the tandem and ovoid. And then we will scan again to make sure that everything is in place. So our job is mainly there just to, our doctors that do brachy are male, so they need a female chaperone. So I end up being a chaperone, and we're just there to help along, like make sure the patient is breathing and just helping out. And then we facilitate with the scan.
Fantastic. Oh, and we have another question that came in. In
Okay.
the case of a patient who has a tumor of the cavum that grows and pushes the ocula out of the orbit, how can you make a head and neck mask for such patient to minimize pain to be exposed?
What we have done is we'll put like a little gauze over that eye that is protruding. We'll wet and put some gauze on it. We will make the mask, let it harden, cut out where that eye is, let it harden, take the mask off, cut it out, put the mask back on, and then continue with the scan. So if there's anything that's protruding, we have a lot of head and neck patients that have, like a fungating mass on the side of their neck. We will cut that part out so as to not to like touch it or irritate that skin.